So after discussing the coronary artery disease patients and the heart failure patients, let's go through the patients with valvular heart disease undergoing non-cardiac surgery. Is there a big risk for patients who have valvular heart disease and they are scheduled for non-cardiac surgery? Valvular heart disease, of course, increase the risk of perioperative cardiovascular complications during the non-cardiac surgery. The magnitude of risk is highly variable and depend on the severity of the valvular heart disease and the type of non-cardiac surgery. But it is particularly increased in patients with obstructive valve pathology. As we all know, severe symptomatic aortic stenosis or severe symptomatic mitral stenosis are considered active cardiac condition, and they increase the risk of perioperative complications. This is because these patients cannot tolerate the perioperative volume shifts and the arrhythmias and lead to rapid decompression. The first recommendation in patients with valvular heart disease is clinical and echocardiographic evaluation, if not recently performed, is recommended in all patients with known or suspected valvular heart disease who are scheduled for elective or high-risk non-cardiac surgery, elective intermediate or high-risk non-cardiac surgery. So any patient having a valvular heart disease undergoing intermediate or high-risk non-cardiac surgery, you should examine him clinically and do an echocardiography. The first valvular lesion is the aortic stenosis. Severe symptomatic aortic stenosis is a significant risk factor for post-operative MI, heart failure, and predictor for the 30-day and long-term mortality after NCS. So just the patient having a severe symptomatic aortic stenosis put him at high risk. So what does the guidelines say about the patient with severe aortic valve stenosis? The first step, as any valvular disease, you should do clinical examination, ECG, biomarkers, transthoracic, possibly if you need transesophageal, put the patient on optimal directed medical therapy, and then go for the multidisciplinary approach. The first question, does the patient with severe aortic stenosis have symptoms or not? If he is symptomatic, it will differ than he is not symptomatic. If the patient of severe aortic stenosis is symptomatic, we classify them into a low risk or intermediate or high risk non-cardiac surgery. A low risk surgery, if he is symptomatic and he undergoing a low risk non-cardiac surgery, you check for the patient risk for valve procedure. Is it low or high? If the valve procedure is high, then you go for non-cardiac surgery without additional procedures. If the patient is safe to undergo valve replacement, so individual decision should be made about the necessity of valve procedure before the non-cardiac surgery. If the patient is undergoing an intermediate or high risk non-cardiac surgery, you should tackle the aortic valve. If the patient is safe to go for valve procedure, you should go for TAVI or surgical valve replacement. If the patient is high risk for valve procedures, then you should consider balloon aortic valvotomy before non-cardiac surgery if feasible. This if the patient is having symptoms. If the patient does not have symptoms, you will check for the ejection fraction if it's less than 50. If the answer is yes, again, if it's low or intermediate risk surgery, no additional procedures. If he is high risk, you check for the valve procedure. You should tackle the valve procedure. If it's a low risk patient, do TAVI or surgery. If not, then balloon aortic valvotomy. So to conclude الجزء ده هو السيفير aortic stenosis هو يا سيمتوماتيك يا مش سيمتوماتيك. لو سيمتوماتيك والعيان داخل يعمل intermediate او high risk surgery يبقى لازم نعمل حاجه الاورتيك فالف، يا تافي يا اما نعمل له سيرجري، يا اما لو ما فيش حاجه نافعه خالص نعمل له بالون للاورتيك فالف. لكن لو داخل يعمل low risk non cardiac surgery وهو عنده severe symptomatic aortic valve disease. في الحالة دي هنشوف العيان هو يعني feasible ليه الفالف ريبليسمنت ولا لا. لو feasible ممكن نعملها، لو لا يبقى يخش يعمل اللو ريسك نون كاردياك سيرجري وخلاص. لو العيان عنده سيفير اورتيك ستينوزز وما عندوش سيمتومز بس الايجكشن فراكشن بتاعه اقل من 50%، لو هو هاي ريسك فقط هنعمل له انترفنشن سواء كان تافي او سيرجري او بالون. لكن لو هو لو او انترميديت ريسك، لو ايجكشن فراكشن بتاعه بريزيرفد و asymptomatic severe aortic stenosis, go for the low risk surgery as planned. So for the aortic stenosis, the aortic valve replacement, whether it's surgical or TAVI, is recommended in symptomatic patient with severe aortic stenosis, asymptomatic or severe, who are scheduled for elective, intermediate, or high risk non-cardiac surgery. In asymptomatic patient with severe aortic stenosis, it should be considered اننا نعمل لهم surgical او تافي اللي هم لو الايجكشن فراكشن بتاعهم اقل من 50%. في العيانين بقى اللي عندهم severe aortic stenosis وعايزين يخشوا يعملوا time sensitive non cardiac surgery او التافي والسيرجري are unfeasible، البالون ممكن تبقى bridge to definitive aortic repair، يعني يعمل البالونه ويخش يعمل السيرجري وبعد كده نطلع نعمل له الاورتيك فالف later on when feasible. What about the aortic regurgitation? The aortic regurgitation, the indication to do the surgery before the aortic valve surgery before the non-cardiac surgery is when you have a patient with severe aortic regurg that is symptomatic, or a patient with severe aortic regurg that is asymptomatic but his left ventricular end systolic diameter more than 50, or a patient with severe aortic regurg that is asymptomatic and his indexed left ventricular end systolic diameter more than 25 per meter square, or if he has severe asymptomatic aortic regurgitation with ejection fraction less than 50. So either a severe symptomatic or severe asymptomatic with certain criteria: dilated end systolic diameter or impaired ejection fraction less than 50%. Regarding the mitral stenosis, in patients with moderate to severe, which patient should we tackle the mitral valve before the non-cardiac surgery? The answer is in moderate to severe rheumatic mitral stenosis, which the guidelines defined as less than mitral valve area less than 1.5 centimeter square, with symptoms or systolic pulmonary artery pressure more than 50, you should do a valve intervention, whether a percutaneous balloon commissurotomy or a surgery before elective intermediate or high risk non-cardiac surgery. So valve area less than 1.5 with symptoms or with systolic pulmonary artery pressure more than 50. After this, let's talk about patients with secondary mitral regurgitation. Because these patients, especially if it's of ischemic etiology, are at increased risk of cardiovascular complication during non-cardiac surgery. So the patients with this algorithm is not for all the mitral regurgitation, it's only for the secondary mitral regurgitation. The first question, is it an elective or time sensitive? For both, we will do clinical exam, ECG, biomarkers, and echo. For both, we will go for guideline and directed medical therapy. But if it's elective, the guideline directed medical therapy should include the CRT and should include the myocardial revascularization if we have time, it's not sensitive. Then we do a multidisciplinary approach. Whether the patient, the symptoms improved or not. If the symptoms improved, go for the non-cardiac surgery. If not, we will see. So if the patient still have symptoms and he is undergoing low risk, nothing more to be done. If it's intermediate or high risk surgery, you should tackle the mitral valve, whether a transcatheter edge-to-edge repair or surgery repair when possible, depending on the eligibility according to the decision of the heart team. If the patient is inoperable or at high procedural risk, then consider the non-cardiac surgery without strict monitoring. So for the severe secondary mitral regurgitation, you should do the basic you do for every patient. You should put the patient on guideline medical therapy, which should include CRT and revascularization if it's elective. And then you check the symptoms improved or not. The symptoms improved, go for the non-cardiac surgery. Does not improve, if it's intermediate or high risk, you should tackle the mitral valve before surgery if feasible. And these are the recommendations for the mitral valve regurgitation. We have the secondary. Let's start with it because this is the algorithm. In patient with severe secondary mitral regurg who remain symptomatic despite guideline-directed medical therapy, including CRT if indicated, valve intervention, transcatheter or surgery should be considered before non-cardiac surgery in eligible patients with an acceptable procedural risk. The criteria to intervene with mitral regurgitation, if it's either symptomatic severe mitral regurg or asymptomatic with dilated end-systolic diameter or reduced ejection fraction less than 60, you should intervene for this primary mitral regurg. When dealing with valvular heart disease, let's not forget if we are dealing with a prosthetic valve, the bridging rules from the last lecture. And when dealing with any valvular lesions like rheumatic heart disease, do not forget the prophylaxis against the infective endocarditis. Let's take a patient to help understand the valvular heart disease. This is a 73-year-old woman with heart failure, NIHA class 3, and severe mitral regurgitation that is of secondary type due to the heart failure. She has a rate of 1 per year heart failure decompensation. She has an impaired ejection fraction of 35, a dilated end-systolic diameter of 68, and she has an early stage breast cancer. So this is a time-sensitive surgery. The comorbidities, she has a chronic coronary syndrome that she was revascularized for. She has a permanent AF with pacemaker implanted due to bradyarrhythmia. She has metabolic syndrome, hypertension, dyslipidemia, type 2 diabetes, obesity, body mass index more than of 30, and she has a CKD. So it's a complicated patient. When revising the risk of surgery, as we always do, this is a low-risk surgery, and the patient is having severe mitral regurg, she's having ischemic heart disease, and she's having impaired ejection fraction. So what is the most appropriate management? Should we do transcatheter edge-to-edge repair? Should we optimize the heart failure treatment and that's it? Should we proceed to the non-cardiac surgery? Or should we minimally do minimally invasive surgical mitral valve repair? We go back to the algorithm of the secondary mitral regurgitation. This is a time-sensitive. You should do all this and do optimal guideline-directed medical therapy and check for the symptoms. And if it's just a low-risk non-cardiac surgery, even if she has persistent symptoms, you should proceed without any additional procedure. So the best option is to optimize her heart failure medication and then send her to the surgery. Let's take another valvular heart disease patient. This is a 75-year-old man with heart failure, NIHA class 3, and severe dysfunction of the surgical mitral bioprosthesis. He has mitral bioprosthesis. He has severe mitral regurg related to the leaflet dysfunction, and he also has a paravalvular leak. He has frequent heart failure hospitalizations. His NT-proBNP is high. He also has hemolytic anemia because of the valve with hemoglobin of 8.9. He has a pancreatic cancer qualified for surgical approach. He has permanent AF, hypertension, type 2 diabetes, and chronic kidney disease. The duodenopancreatic surgeries are high-risk surgery. So should we redo the mitral valve, proceed to non-cardiac surgery, do a valve-in-valve transcatheter mitral valve replacement, postpone the non-cardiac surgery until the hematology consult of hemolysis? We go back to the algorithm. This is again a time sensitive and the procedure is high risk. So in this case, we should tackle the mitral valve, whatever is feasible and available at the facility. At their facility, they had the option to do a transcatheter mitral valve replacement, and they did that to the patient. 30 days for that patient follow-up. He has a trace mitral regurg. He changed from NIHA 3 to NIHA 1. His NT-proBNP level dropped marvelously, and his hemoglobin rose to 10.5. This concludes our talk about the valvular heart disease. Let's go through the rest rapidly. The first one is the arrhythmias. They discussed that there are 3 types of arrhythmias that you could encounter: the supraventricular arrhythmias, and the ventricular tachycardia in structural heart disease, and the rare entity, the idiopathic VT in a structurally normal heart. Of course, you should do for all patients ECG and echo, but in those with VT in a structural normal heart, you should consider coronary angio and cardiac CT or MRI. Managing the acute management for the SVT, you should go for vagal maneuvers, intravenous adenosine beta blocker, calcium channel blocker, electrical cardioversion if unstable. And for the future prevention, you should go for oral beta blocker or calcium channel blocker, catheter ablation if recurrent despite optimal medical therapy. Regarding the ventricular tachycardia in structural heart disease, you should treat the underlying heart condition. Of course, this patient will benefit from beta blockers. You might need amiodarone. If the patient is unstable in the acute management, you should go for electrical cardioversion. The long-term therapy should include oral beta blocker or amiodarone. And if recurrent despite medical treatment, you should go for catheter ablation. These are the recommendations. For the SVT, in patient with SVT controlled by medication, it is recommended that his antiarrhythmic should continue during the perioperative period. And in patient with symptomatic, recurrent, or persistent SVT, despite the treatment prior to high-risk non-urgent surgery, you should do ablation before the surgery, which is a rare situation to have a persistent or recurrent SVT despite treatment, and the surgery is high risk. You should do ablation in this condition. Regarding atrial fibrillation with hemodynamic instability undergoing non-cardiac surgery, in AF with acute or worsening of hemodynamic instability undergoing non-cardiac surgery, emergency electrical cardioversion is recommended, but always remember that this is rare. It is very rare to see an AF causing hemodynamic instability, and with cardioversion, you carry a very high risk of thromboembolism, so you don't go for this option easily. And you can go for amiodarone for acute control class 2B. Regarding the ventricular arrhythmias, if the patient is having symptomatic monomorphic VT related to a myocardial scar despite optimal medical therapy, you should send the patient for ablation before surgery, and it is not recommended to initiate treatment of asymptomatic PVCs during non-cardiac surgery. It is better not to start beta blockers for the perioperative period if the patient is not on. Regarding the bradycardias, you should follow the guidelines on cardiac pacing and resynchronization as always. The important point I need to point here is that the patients should do reprogramming at least 1 year before the surgery. And if the surgery is having electromagnetic interference, you should, and the patient is pacemaker dependent, you should change the programming of the pacemaker before the surgery to be VOO instead of depending on the patient. So the patient لو كان معتمد بالكامل على البيسميكر والعيانين هيستخدموا كوتري مثلا وهيبقى فيه electromagnetic interference في العملية، لازم يتعمل له بروجرامينج للبيسميكر بتاعه قبل العملية انه يبقى بيدي ما بيعتمدش على انه يسنس الاتريا بتاعت العيان علشان ما يتلخبطش مع الالكترومagnetic فيلد، فبالتالي يتحول لفي او قبل السيرجري. In adult congenital heart disease هم قسموهم لماينور وانترميديت وسيفير ريسك، شبه التقسيمه بتاعه البريجننسي والكونجنتال هارت ديزيز. السيفير ريسك اللي هم العيانين السيانوتيك هارت ديزيز الانكوركتد، او العيانين عندهم بالمونري هايبرتنشن او عندهم كومبلكس كونجنتال هارت ديزيز. الماينور ريسك اللي هم عندهم سمول ديفكتس ما تصلحتش. الانترميديت باقي الكونجنتال هارت ديزيز ان بتوين، وما قالوش ريكومنديشنز قويه على الكونجنتال هارت ديزيز غير ان انت محتاج تبقى عندك سبيشالست والسنتر يكون اكسبيرينسد في الادلت كونجنتال هارت ديزيز قبل النون كاردياك سيرجري. Regarding the pericardial disease, the first question, is it common to have a pericardial disease and non-cardiac surgery? Active pericardial disease is infrequent at the time of non-cardiac surgery, but if it's there, it is potentially life-threatening. It is very important to know the etiology of the pericardial disease, whether it's viral, it's bacterial, malignant, or whatever. What pericardial disease prevents you from surgery? The first thing is acute pericarditis. Acute pericarditis is a clear indication to postpone an elective surgical procedure. However, in cases with undeferrable non-cardiac surgery, attention is required regarding to drug-drug interactions. So if the patient is having acute pericarditis مش هيعمل عملية. لكن لو انت عندك بقى عملية والعملية دي ما تتأجلش وعنده pericarditis وانت مدخله، مهم قوي تراجع الدراج interactions، وهنشوف في السلايد الجاية ايه هي الدراج interactions المهمة. طبعا imminent cardiac tamponade absolute contraindication ان العيان يخش السيرجري. لازم قبل السيرجري يتعمل له بريكارديوسنتيسيس وبعد كده نبعته يعمل الجراحه. ايه هي دراج انتراكشنز؟ مشهور فيهم الكولشيسين. الكولشيسين في جزء منه ميتابولايزد في الليفر وفي جزء صغير عن طريق الكدني، وبيزود السنسيتيفيتي تو سنترال نيرفس سيستم ديبريسنت واكزيرت ريسبيراتوري ديبريسنت ايفكت هو نفسه. كمان من ضمن الدراج انتراكشنز المهمه الستيرويدز والانترلوكين 1 ريسبتور انتاجونست، دول بيسبرس الاميون سيستم وهيأخروا الوند هيلينج. طب لو انت عندك عيان عنده سمول اور مودريت بريكارديال افيوجن، او مور امبورتنتلي لو العيان بتاعك عنده كونستريكتيف بريكاردايتس، ايه اللي تعمله في البيري اوبراتيف بيريود؟ هدفك انك انت تهتم جدا بالبريلود زيه زي العيان بتاع الهوكم. البريلود should be optimized perioperatively، انك تديله IV fluids قبل الجنرال anesthetic induction to facilitate ventricular filling. المانيبيوليشن والميديكيشن اللي بتقلل الفينس ريتيرن تو ذا هارت should be avoided or minimized. لو انت العيان ده لازم تحطه على ميكانيكال فنتيليشن حاول تبعد عنه، ولكن لو انت مضطر حاول تقلل التايدال فوليومز وتستخدم ريسبيراتوري ريت عالي علشان ما يقللش قوي الفينس ريتيرن. These were the recommendations for the pericarditis. In patients with acute pericarditis deferring elective, you should defer elective non-cardiac surgery until complete resolution of the underlying process. Avoid elective non-cardiac surgery under general anesthesia until colchicine or immunosuppressive therapy is completed may be considered. علشان الدراج interactions بتاعته. البلمونري ديزيز بقى والبلمونري hypertension. The coexistence of pulmonary disease in cardiac patient undergoing non-cardiac surgery بيزود الoperative risk. The pre-existing pulmonary disease has a significant impact on perioperative risk, but the most common effect is an increased risk of post-operative pulmonary complication. يعني هم بيزودوا operative risk مش عشان الكاردياك condition، بيزودوه علشان post-operative pulmonary complications، بالذات بعد الابdominal or thoracic surgery في العيانين السموكرز. COPD ده طبعا major cause of morbidity and mortality, have an increased risk of cardiovascular disease. والpost operative pulmonary complication result in significant mortality and morbidity. طب لو عيان COPD داخل non-cardiac surgery, what should we do? We should use the preoperative period for education. يا ريت يبطل تدخين قبل الجراحة بشهرين. لو ينفع يعمل chest physiotherapy و lung expansion maneuvers. ورينيوتريشن if required. يتحط على بيتا اجونست وانتي كولينرجيك ايجنتس وما توقفوش لغايه يوم العمليه. In some cases short-term inhaled أو systemic steroids may be considered. ولو العيان عنده pulmonary infection ال appropriate antibiotic should be administered على الأقل 10 أيام، وطبعا مش هندخل عيان بيسخن non-cardiac surgery. في بعد كده حاجة اسمها ال obesity hypoventilation، ودي different عن ال COPD و different عن ال obstructive sleep apnea، ودي triad of obesity و daytime hypoventilation و sleep disordered breathing. ودي الريكومنديشنز بتاعه البلمونري ارتيريال هايبرتنشن. البلمونري ارتيريال هايبرتنشن في فاكتورز في العيان بتزود الريسك اوف سيرجري، وفي فاكتورز في السيرجري بتزود الريسك. الفاكتورز بتاعت السيرجري هي الامرجنسي لو التخدير طول اكتر من 3 ساعات، ولو احتاجنا ندي فازو بريسورز. الفاكتورز اللي في البيشنت الحاجات اللي احنا كنا عارفينها من البلمونري هايبرتنشن، لو الفانكشنال كلاس بتاعته اكتر من 2، لو ال 6 minute walk test بتاعه قليل، لو هو عنده associated coronary heart disease او pulmonary embolism او عنده kidney او severe right ventricular dysfunction. طب ايه recommendations لعيان عنده pulmonary arterial hypertension داخل يعمل سيرجري؟ هيكمل على الكرونيك ثيرابي بتاعه في البيري اوبراتيف بيريود، مش هيوقفه. لازم نعمل له هيمودايناميك مونيتورنج لغايه 24 ساعه بعد العمليه. ولو جاله بقى بروجريشن للرايت هارت سايد هارت فيلير، ممكن نفكر نزود الدايوريتك دوز، وممكن لو نيسيسري نحط اي في بروستاسايكلين. ولو هنستخدم اينوتروبيك ايجنتس نفكر في الثلاثه اينودايليتورز دول اللي هم الدوبيوتامين والميلرينون والليفوسيماندان، بالذات الميلرينون لانه ده بيبقى ليه زي بوزيتيف ايفكت على البلمونري فاسكليتشر وبيعمل فازو دايليتيشن اكتر ما بيعمل فازو كونستريكشن. طب العيانين اللي عندهم سيستميك هايبرتنشن وداخلين يعملوا سيرجري، مش هنأجل السيرجري لو عيان جريد 1 اور 2 هايبرتنشن. الكات اوف اللي هنأجل علشانها السيرجري هي لو السيستوليك اكتر من 180 والدايستوليك اكتر من 110. والحاجه المهمه قوي ان احنا نبعد عن اللارج بيري اوبراتيف بلاد بريشر فلكتويشنز. ودي ترايلز كتيره بينت ان الفلكتويشن في البلاد بريشر is associated with morbidity ومورتاليتي، لدرجه انه لما بنكيب الديفرنس around 10% بس من البيز لاين، ده بيقلل ريسك اوف بوست اوبراتيف اورجان ديسفانكشن. في العيانين بقى اللي عندهم chronic hypertension وداخلين elective non-cardiac surgery it is recommended to avoid fluctuations في البلاد pressure. دي نقطة مهمة. لو هم stage 1 or 2 hypertension you don't defer السيرجري. لو هم عندهم بقى hypertension وانت عندك وقت، مفيش مشكلة انك تدور على hypertension mediated organ damage زي renal affection، زي ايا كان ايه هو الاورجان دامج، تعمل له ايكو وهكذا. البريفرال ارتيريال ديزيز، ودي من الحاجات المهمه قوي ان العيانين دول بيبقوا هاي ريسك فور سيرجري اصلا، وبيجوا لنا كتير وبيبقى فيري كومن ان هم عندهم كوروناري ارتي ديزيز. بس اننا نعمل لهم روتين ريفيرال فور كاردياك ورك اب وكوروناري انجيو والحاجات دي ات از كلاس 3. طب امتى نعمل لهم القصه دي؟ نعملها لهم لو كانوا في الاتي: اول حاجه لو عندهم poor functional capacity، او عندهم significant risk factors زي مثلا عندهم angina, decompensated heart failure, valvular disease, significant arrhythmias. هنبعتهم في الحاله دي for cardiac workup optimization قبل ما يروحوا يعملوا peripheral arterial disease او abdominal aortic aneurysm. فلو انت الفانكشنال كاباسيتي بتاعتهم cannot be assessed، او لو هم عندهم risk factors، في الحاله دي بس هتبعتهم cardiac assessment. السيريبروفاسكولار ديزيز برضو انك انت تعمل لهم routinely carotid artery imaging is not recommended. لكن امتى تعمل لهم imaging؟ تعمل لهم imaging لو هم جالهم TIA او ستروك في اخر 6 شهور وما تعمل لهمش revascularization. الرينال ديزيز هنأجلها لان احنا هنتكلم in detail على العيانين اللي عندهم داخلين يعملوا رينال ترانسبلانتيشن لانها حاجه مهمه. العيانين الاوبيز برضو نفتكر حاجتين: الاوبيزيتي هايبو فنتيليشن سندروم لازم يبقى معانا سبيشالست قبل الميجور نون كاردياك سيرجري، ولازم نشوف الكارديو ريسبيراتوري فيتنس علشان نشوف البري اوبراتيف كارديوفاسكولار ريسك ان اوبيز لو داخلين يعملوا انترميديت او هاي ريسك نون كاردياك سيرجري. واخر حاجه بقى العيانين اللي عندهم دايابيتس او ديستربد جلوكوز ميتابوليزم، بري اوبراتيف هيموجلوبين A1C is recommended لازم في العيانين دول. ولو الميجرمنت هاز نوت بين لو ما اتعملش في خلال 3 شهور، ولو كان اكتر من 8.5 يا ريت ناجل العمليه لغايه لما الهيموجلوبين A1C يتظبط شويه. وطبعا بينهم كونهم دايابيتس لازم ندور على الحاجات بتاعه الدايابيتك ريسك فاكتورز.